Pancreatic cancer early warning signs. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon here in the UK. And if you or someone you care about has been wondering about pancreatic cancer's early warning signs, you're in the right place. I know hearing about cancer symptoms can feel overwhelming, especially when you're trying to figure out whether vague complaints really need medical attention. But today we're going to cut through the confusion about pancreatic cancer's early warning signs, particularly painless jaundice, epigastric pain, radiating to the back, unexplained weight loss, and new-onset diabetes. By the end of this video, you'll understand exactly what symptoms demand urgent medical attention, when to see your doctor, and most importantly, why catching these signs early can be the difference between a potentially treatable cancer and one that's spread too far. Here's something that might surprise you. Approximately 50% of patients with pancreatic cancer present with painless jaundice, that yellowing of the skin and eyes, particularly when the tumor is in the head of the pancreas. But that's just one piece of the puzzle we're going to explore together. Before we dive into the warning signs, let's quickly establish what we're dealing with. Pancreatic cancer is a malignancy arising from the pancreas, that gland sitting deep in your abdomen behind your stomach that produces digestive enzymes and hormones like insulin. The vast majority, about 85%, are adenocarcinomas arising from the ductal epithelium, which is the part of the pancreas that makes digestive enzymes. Now, why does this matter to you personally? Because pancreatic cancer is one of the leading causes of cancer-related death worldwide, yet only 15 to 20% of patients have potentially resectable disease that can be surgically removed at diagnosis. The reason? Most people don't recognize the early warning signs until the disease has already progressed. Understanding these subtle early symptoms gives you the power to advocate for yourself or someone you love when something doesn't feel right. Jaundice is the yellowing of your skin and the whites of your eyes, and it's one of the most recognizable early signs of pancreatic cancer, particularly for tumors in the head of the pancreas. Now, what does this look like in real terms? Jaundice is present in approximately 73% of patients with tumors located in the head of the pancreas. The jaundice is typically progressive and may be accompanied by itching, sometimes quite severe, darkening of the urine that looks like tea, and pale stools that appear almost clay-like. Here's where it gets interesting. This jaundice is often painless, which is why it's called a relatively early sign. When a tumor in the pancreatic head grows, it obstructs the common bile duct, the tube that carries bile from your liver to your intestines, causing bile to back up into your bloodstream. Now you might be wondering, why is painless jaundice such a critical warning sign? In a case-control study examining over 21,000 patients, the positive predictive value of jaundice for pancreatic cancer in a patient aged 60 or older was 22%. That's about 1 in 5 older adults with jaundice having pancreatic cancer. You can do the math right, that's significantly higher than most other individual symptoms. For all other single symptoms or pairs of non-jaundice symptoms, the positive predictive value was less than 3% even in older individuals. I know when you hear these numbers, it's natural to feel scared. But here's the perspective you need. Jaundice has many causes, including gallstones, hepatitis, and other liver conditions. The key is not to panic, but to seek prompt evaluation. If you're supporting someone through unexplained jaundice, especially if they're over 60 and haven't had gallstones or liver disease, this is when urgent evaluation becomes crucial. I'm talking about having specific questions for your doctor about what's causing the bile duct obstruction. Do we need imaging? How quickly can we get a CT scan or ultrasound? The initial imaging study for someone with jaundice is often transabdominal ultrasound, which has high sensitivity for detecting biliary tract dilation and establishing the level of obstruction. If a pancreatic mass is suspected, a pancreatic protocol CT scan, that's a specialized CT, with multiple phases of contrast injection, provides more comprehensive information. Pain is one of the most frequently reported symptoms, even with small pancreatic cancers less than 2 centimeters. The pain associated with pancreatic cancer has a very characteristic pattern. It's usually insidious in onset, meaning it develops gradually, and has been present for 1 to 2 months at the time of presentation. Now, what does this look like in real terms? It has a typical gnawing visceral quality, that deep aching sensation, and is generally epigastric, which means in your upper abdomen just below your breastbone. But here's the telltale sign. It radiates bilaterally under the ribs and straight through to the mid-back. In observational series, about 79% of patients reported abdominal pain, with 71% specifically describing epigastric pain and 49% reporting back pain. Think about it this way. If you've got persistent upper abdominal discomfort that seems to wrap around to your back, gets worse when you lie flat, and isn't responding to antacids or standard treatments, that's not your typical heartburn or muscle strain. The proximity of pancreatic tumors to the celiac plexus, that's a network of nerves behind your pancreas, explains why this pain can be so characteristic and why it often has that radiating quality to the back. Now, what about the pattern of this pain? Most patients with pancreatic cancer and abdominal pain have pain that has been present for more than 3 days but not for many months. As such, they generally fall into the category of subacute pain, meaning weeks to a couple of months. We're not talking about pain that's been there for years. Pancreatic cancer pain typically develops over weeks to months, not years. If this applies to you or someone you care about, here's what matters most. Persistent epigastric pain lasting more than 2 to 3 weeks, especially combined with weight loss, demands investigation beyond simple reassurance. The diagnostic approach generally depends on the history location of the pain and the general suspicion for benign versus malignant disease based upon associated symptoms such as weight loss. If you're worried about someone you love, showing these warning signs permission to feel worried is completely appropriate. The key is channeling that concern into action. Weight loss is one of the most common presenting symptoms, appearing in approximately 85% of patients with pancreatic cancer in observational series. But let me give you perspective on what we mean by significant weight loss. When we talk about unexplained weight loss with pancreatic cancer, we're typically seeing loss of 10% or more of body weight without trying. Now, what does this look like in real terms? That's about 17 pounds for someone who weighs 170 pounds, or roughly 20 pounds for someone at 200 pounds. This isn't the kind of gradual weight change that happens over years. This is noticeable weight loss over weeks to months that you, your family, or your friends definitely pick up on. Now, what about the mechanisms behind this? Weight loss in pancreatic cancer happens through several pathways. Reduced appetite, which affects about 83% of patients. Difficulty eating due to nausea, affecting 51%. And something called steatorrhea, which means fatty, loose, foul-smelling stools because the pancreas can't produce enough digestive enzymes. Steatorrhea was present in 28% of patients with pancreatic head lesions. Here's something that might surprise you. If you're caring for someone with unexplained weight loss, especially an older adult who's always maintained a steady weight, and they're also describing food not appealing to them anymore, or having loose, foul-smelling stools, these combinations significantly increase concern for pancreatic pathology. The timeline expectation here is crucial. We're talking about weight loss that's noticeable over 2 to 3 months, not gradual changes over years. If you already have risk factors like smoking, diabetes, or a family history of pancreatic cancer, unexplained weight loss of this magnitude is your body telling you loud and clear that something needs investigation. These concerns are completely normal and understandable. The key is to act on them. This is where it gets particularly interesting from a clinical standpoint. Pancreatic cancer may present with the sudden onset of diabetes mellitus, and in up to 25% of cases, the disease may be heralded by new-onset diabetes. That's diabetes diagnosed within 2 years or less. Now, what does this look like in real terms? Studies show that diabetes is more prevalent in pancreatic cancer cases, 47%, compared with controls at 7%. But here's the critical detail. Among those with diabetes and pancreatic cancer, 74% had their diabetes diagnosed in the preceding 2 years compared with 53% of controls. Let me put this in perspective. If you're a previously healthy weight older adult, let's say you're in your 60s or 70s, and you suddenly develop diabetes without the typical risk factors like obesity or strong family history, especially if you're also experiencing unintentional weight loss, your risk of pancreatic cancer is especially elevated. Here's compelling evidence. After pancreatic duodenectomy, that's the surgical removal of the pancreatic head, diabetes resolved in 17 of 30 patients, or 57%, with new-onset diabetes. This tells us the diabetes was actually caused by the cancer, not the other way around. Now you might be wondering, should everyone with new-onset diabetes be screened for pancreatic cancer? Remember, pancreatic cancer affects about 13 in 100,000 people per year. It's relatively uncommon. Current guidelines say no to universal screening, because the average lifetime risk of developing pancreatic cancer in the general population is too low at approximately 1 in 60 in the United States. However, if you're supporting someone with new-onset atypical diabetes in an older adult, especially one who's losing weight, despite higher blood sugars, these red flags together warrant discussion with your doctor about appropriate imaging. For high-risk individuals undergoing screening, those with family history or genetic syndromes, urgent imaging within 2 weeks with endoscopic ultrasound magnetic resonance, cholangiopancreatography, or pancreatic protocol CT scan is recommended when new-onset diabetes develops. But here's where it gets interesting. The combinations matter most. The awareness of risk factors, genetic predisposition, age over 60, smoking, and diabetes may lead to an earlier and more aggressive evaluation for pancreatic cancer in patients who present with symptoms suspicious for the disease. What I want you to understand is that no single symptom by itself necessarily means pancreatic cancer. The positive predictive value is less than 3% for most individual symptoms except jaundice. But when you start seeing combinations, like epigastric pain plus weight loss, or new-onset diabetes plus unexplained weight loss, or painless jaundice in an older adult, that's when alarm bells should ring. Research demonstrates that symptoms are often present for 1 to 2 months before diagnosis, which means there is a window for detection. The challenge is that these symptoms are nonspecific. They could be many things, including pancreatitis, irritable bowel syndrome, and other non-cancerous disorders. In fact, in a landmark study, 57% of patients with symptoms highly suggestive of pancreatic cancer had other diagnoses. But awareness is key. If you're worried about someone you love showing these warning signs, The key is channeling that concern into action. Specific questions for their doctor, advocating for appropriate imaging, and not accepting vague reassurance when symptoms persist or worsen. Give yourself permission to be persistent. You know your body or your loved one best. So here's your bottom line. Let's talk about the 3 categories of action you can take. Things you can start this week. Document your symptoms precisely. Keep a symptom diary, noting when pain occurs, its exact location, whether it radiates to your back, and what makes it better or worse. Record your weight weekly if you're concerned about unexplained weight loss. Use the same scale at the same time of day. Note the color of your urine and stools. Take photos if needed, because describing dark urine or pale stools can be subjective, and these photos can help your doctor assess urgency. Know your risk factors. Write these down to discuss with your doctor. Are you over 60? Do you smoke or have you smoked? The relative risk for developing pancreatic cancer among smokers is at least 1.5 times higher than non-smokers, and it increases with the amount consumed. Is there a family history of pancreatic cancer or related genetic syndromes? Do you have long-standing diabetes, chronic pancreatitis, or recent onset diabetes within the past 2 years? If you're supporting someone through concerning symptoms, help them track these warning signs objectively. Attend medical appointments with them to advocate for thorough evaluation. Sometimes having another person present helps ensure important details aren't missed. Things to discuss with your doctor. Come prepared with specific questions. I've had persistent epigastric pain radiating to my back for X weeks. What tests can rule out pancreatic pathology? I've lost X pounds in Y months without trying. Combined with other symptom, do I need abdominal imaging? I've developed jaundice. What's the next step to determine if this is a bile duct obstruction from a pancreatic mass? I was just diagnosed with diabetes at age, and I'm also experiencing weight loss. Should we do imaging to screen for pancreatic cancer? Ask about appropriate imaging. For jaundice, initial testing often includes transabdominal ultrasound, which has high sensitivity for detecting biliary tract dilation. However, if a pancreatic mass is suspected, a pancreatic protocol CT scan provides more comprehensive information about the presence of a mass and whether it can be surgically removed. For epigastric pain and weight loss without jaundice, a contrast-enhanced CT of the abdomen and pelvis is typically the preferred initial test. For example, if you present with epigastric pain, your doctor should order serum aminotransferases, alkaline phosphatase, and bilirubin to determine if cholestasis bile duct obstruction is present. They should also evaluate for acute pancreatitis with a serum lipase test. When to seek urgent evaluation. Seek medical attention within days, not weeks, if you experience new-onset jaundice, especially if painless and accompanied by dark tea-colored urine and pale clay-colored stools. Persistent epigastric pain lasting more than 2 to 3 weeks that radiates to the back and isn't responding to standard treatments like antacids or over-the-counter pain relievers. Unintentional weight loss of more than 10 pounds over 2 to 3 months, especially if combined with other warning signs over 2 to 3 months, especially if combined with other warning signs like decreased appetite. The general diagnostic evaluation includes serologic evaluation and abdominal imaging, with additional testing directed based upon findings in your clinical presentation. If a mass is identified, referral to a multidisciplinary team at a high-volume center experienced in pancreatic cancer should occur immediately. Let me quickly recap the key points for you. First, painless jaundice is the most specific early warning sign, particularly for pancreatic head tumors. The positive predictive value of jaundice for pancreatic cancer in a patient aged 60 or older was 22%. That's about 1 in 5 older adults with jaundice having pancreatic cancer, significantly higher than other individual symptoms. Second, the combination of symptoms matters more than any single symptom. Epigastric pain radiating to the back, plus weight loss, or new-onset diabetes plus weight loss in an older adult are red flag combinations that warrant prompt imaging within 1 to 2 weeks. Third, early detection through recognizing these warning signs and pursuing appropriate imaging promptly can mean the difference between potentially resectable disease and advanced cancer. The 5-year survival for stage IA disease has dramatically improved, nearly doubling from 45% in 2004 to 84% in 2012 for the earliest caught cases. This shows that when we catch pancreatic cancer, early outcomes can be significantly better. For additional reliable information, I recommend the National Cancer Institute at cancer.gov for comprehensive information about pancreatic cancer diagnosis and treatment, and Cancer Research UK at cancerresearchuk.org for UK-specific guidance on pancreatic cancer symptoms and when to see your doctor.